So let's go ahead and get started. My name is Matthew Piecha. I just want to thank everyone for joining us today. This is the Ethics Committee Consortium webinar series. We're doing kind of a special weekly installment on the COVID-19 pandemic and various ethical dimensions around that. So this is the third installment, and we're going to be talking about the ethical considerations of quarantine, isolation, and social distancing. We have a two-part presentation today, so I'm going to try and get through these announcements quickly so we can get to it. Just for people who are new to this series, we record these and post them to our YouTube channel afterwards. So if you go to YouTube and search Practical Bioethics, you'll be able to find recordings of these webinars there. If you know people who are interested but unable to tune in, feel free to share it with them. A couple of housekeeping issues. We like these webinars to be kind of discussion events as well as presentations. So please engage with the Q&A and the chat tools that you'll find in Zoom. I'll be keeping an eye on those throughout the presentation, and if anyone has any questions, I'll make sure to get them answered by our panelists. So today we've got a couple of presentations for you. First, I'm gonna hand it off to Darrin, who is a member of our board and also the Executive Dean, College of Osteopathic Medicine, and Vice President for Health Affairs at the Kansas City University for Medicine and Biosciences. I think just with that, it's probably best that we just hand it off and go ahead and get started. So Darrin, you take it away.
Great, thank you, Matthew. First, I'd like to welcome everybody. This is a very big topic to discuss right now and actually has a tremendous amount of bearing on the last few weeks and the few weeks that are going to be coming up, potentially the few months that are coming up with our current COVID infection and the national responses. First thing I'd like to do is just let you know that these opinions are my own opinions and do not represent the opinions of Kansas City University. That I have no affiliations that are conflicting with this discussion, nor are they directing this discussion. And then finally, I am a board member of the Center for Practical Bioethics. One of the things I wanted to make sure that we do is start with the definitions of what we're talking about. I have realized over the last few weeks, as I'm having discussions with various people and groups, that there is a little bit of confusion over the term quarantine, isolation, and social distancing. Quarantine is essentially a restriction of movement and separating a person who may have been exposed to a disease or a contagion. That means the person is not sick, and generally these are done at home. And the reason we do this is so that we can closely monitor people for signs and symptoms of a developing disease. This is important to help avoid the spread to others. Isolation, on the other hand, is a person who actually has the disease and is sick. And what we do with isolation is actually put them in a place where they can best be cared for. And usually that's in a hospital, but sometimes they can be isolated at home if the symptoms are not that dramatic and not that severe. But the oversight and the observation becomes critical, because should that person get worse, we have the ability to move them into a higher level of care. The goal here also is to protect the uninfected person and to make sure that the population remains healthy. The last term is called social distancing, and this is one that we've all heard about recently. This is a community level intervention that allows us to restrict groups from getting together and creating an opportunity for an infection to spread to others because of close contact. There is a great deal of leeway with this, and it all depends on how much a virus or a contagion is in a community and how aggressive we need to be doing this. These are all very proven ways of treating public health crises and interventions that allow us to decrease the spread to others. I'd also like to spend just a couple minutes talking about the history of quarantine, because I think this is going to be an important one for us to pay attention to help frame some of the questions we'll be talking about in the future. First, quarantine dates back to at least the 14th century, and it was primarily there to control plague. The important note that I want to bring out for this conversation is that it took centuries before Yersinia pestis, the causative agent for plague, was actually discovered. And so the concept of quarantine actually saved thousands, if not hundreds of thousands of lives worldwide, because it was, although not precise and specific to an infection, a tool that was used to help prevent infection to others. In the United States, we see as early as 1738 in Bedloe's Island, now known as Liberty Island, where the Statue of Liberty is, as one of the first places that we actually quarantined travelers because of smallpox and yellow fever. Eventually, most seaports in the United States developed quarantine stations, and these were managed federally through the National Quarantine Act in 1878. This becomes important because it's actually the foundation of many of the laws that are still being used and quoted to develop the process of quarantine and why it is so important from a public health point of view. Let's look at a little bit of baseline data here in the United States and why these tools have remained for many years. Sorry about that. It is very important to understand that we have about 1 million people traveling to the United States every day. Americans take more than 75 million trips a year, and there are 320 travelers arriving in the United States through greater than 300 ports of entry each year. And so these statutes and these laws have been put in place to help us maintain a level of health that does not allow global transmission of diseases to occur. And by and large, they do a good job. Well, there are 20 quarantine stations in the United States. 18 of those fall under the Global Mitigation and Quarantine Division of the CDC. 2 of those stations actually fall under local jurisdictions in Houston and New York, but they're all part of a network to help control the spread of disease. Federal government has been defined in this as having a role in this very specifically for international and interstate travel. And so from there, when we start talking about the obligations for quarantine and the necessity for it at a state and at a local level, it means that there have to be statutes at the state level that allow for quarantine and the public health system to act rapidly. And in fact, every state has statutes allowing for quarantine and isolation to occur. These do vary in scope, they do vary in power. It really truly depends on which state you're in as to how much power each one of these statutes would have. So where does the challenge develop for us? What is it about these questions and quarantining a person that really drive the ethical considerations of what we're talking about? And I'm not sure why these are switching the way they are, so I apologize for that. And basically, the question that we have from a public health point of view is, how do we balance the interest of an individual with the interest of the public's health? How do we protect an individual's right to liberty and the health of the public due to infectious agents? And this is the foundation of the question that we're here to discuss today. The ethical questions that really come up from this start off at a high level in two specific areas. One is justification of a quarantine, and the other is the effectiveness of a quarantine. The answers to these questions are really based on a few pieces of information. Will a quarantine's action actually stop transmission? And the other question is, will, during the quarantine state, the heightened observation of the individual make a difference in transmission of the disease? And so with this foundation, we need to then break it down into a couple of different points. And these are the principles that we often have to ponder, discuss, and realize in order to justify a quarantine order if it is mandated. I should have said in the beginning, and I'll come back to it right now, is that quarantine can be a mandated order, or it can be self-imposed. There are many examples of self-imposed quarantine, and we'll talk about a few of those as we move forward. So if we start with these 4 principles that have to be met in order to justify an order, we can start with the very first one, which is there harm to others if somebody is exposed to the contagion? So examples of this would be Ebola. Very clearly, if you're exposed to Ebola and you contract it, there is a very high likelihood you're going to have a poor outcome and get very ill. Anthrax, on the other hand, is not transmitted from person to person. So it does not meet the principle of harm in order to justify a quarantine. If we look at the second one here, this is proportionality. And we're really talking about the act of a mandated quarantine being proportional to the risk an individual has if they contract this disease or the contagion. So this is where the principle of voluntary versus mandatory comes in. There are many examples of this. The ones I'll use here are flu versus Ebola. Every year, if any one of us gets sick with flu, we self-quarantine. We don't go to work, we stay home, we convalesce at home while we're taking our medications. And until we're no longer contagious, we remain isolated from the rest of the community because we know it's important to do that. That is not mandated. Things like Ebola, however, when they came into the United States, there were mandated quarantines. If you were exposed to somebody but not yet showing symptoms, you were pulled away from society so that you could not transmit that to somebody else, because the outcome could have been much more dire than convalescing at home. The third principle that we're going to talk about here is reciprocity. And if we are going to mandate the loss of liberty or the loss of freedom of an individual because of a public health issue, we also have to have certain securities that as a quarantined person, we're not going to be put in an awkward situation or one that is that we're not comfortable with. Basically, we don't want to lose our jobs if we're quarantined. We need to still be able to get food for our families. And if you're the primary breadwinner but quarantined, what are those things that the municipality is going to do to ensure that you're not put under undue stress because of that loss of freedom? The last principle I wanted to talk about was transparency. Transparency is important here because in a democratic society, and one that is based on principles of trust and justice, we also need to make sure that we're communicating clearly and efficiently and transparently the reasons why somebody is being quarantined. This allows for a challenge if it is not believed to be justified, and allows a democratic society to continue producing or working within the environment that it was established under. What I'd like to do now is go back to the three principles that we need to look at from a challenge point of view. We're going to look at the principle of harm, the principle of proportionality, and the principle of transparency. What if we don't know the magnitude of harm of an individual contagion? What if we just don't have all the information about its characteristics and how it is transmitted? The question that pops up with this is, if we don't know, does that change our ability to mandate quarantine? Some people would argue that that is critically important, that if we just don't know, the best thing to do is to stay away. Others would argue, until we know, we should not be doing this because it is an infringement on our liberty. These are challenges that we do have to pay attention to, because what they end up doing is challenging the very essence, the very foundation of how our society has been put together. The balance of the public's health and an individual's right to liberty is a very, it's a very tenuous balance, and it's a very important balance to maintain, but it also has to have certain restrictions around it so that it's just not thrown out there and being used in a punitive way. So in summary, I wanted to review just the few things that we talked about, and then we'll have a chance to open this up for questions. First, quarantine is sometimes described as a blunt instrument to control infectious diseases. In the example that I gave, early in the 14th century, to control the spread of plague, nobody knew what the organism was, but they did know that if we could prevent contact and prevent spread, we would prevent deaths. And in and of itself, this blunt instrument actually saved thousands, if not hundreds of thousands of lives worldwide throughout the courses of plague. There are circumstances where the use of quarantine is necessary, and it may be the only means, at least initially, to control the spread of an infectious disease, especially when we don't have all the answers about that disease. The foundation of the question, is quarantine ethical, is really based on effectiveness and justification of this tool being used. And the 4 principles that help satisfy the justification for a mandated quarantine are harm, proportionality, reciprocity, and transparency. With that, I'll pause now, and if we have any questions, we can have the panel address those. Thank you for your time.
All right, so I'll just remind everyone who's tuned in that there's a Q&A instrument and a chat tool that you can use to submit questions, and I'll be keeping an eye on those and we'll read them out live.
Yes, so let me begin. This is John Carney. I'm with the center, and I want to thank both Darrin and Erika for being with us today. My question, Darrin, is and maybe I missed the definition part, but do you see social distancing as a gradation of quarantine, since most of us are obviously not ill or not exposed, at least at the moment? And so it really is kind of an element of quarantine in general. And then the second part of my question is, if that's true, and we know that if we accept the fact that there's, say, a 1% lethality rate here, as opposed to the 0.1% that we have with flu, do we owe vulnerable patients who are much more likely to succumb to this illness something extra as a society that might threaten, we might see it as a threat to our socioeconomic status, but we owe them that simply because they are more vulnerable in their position in society?
Yeah, John, those are great questions, and I think there are a few things that that need to be tweezed out, as you said. Isolation, social distancing, and quarantine are tools that are used for containment and mitigation, and we've been hearing about the containment and mitigation strategies that are being used across the country and around the world right now. Social distancing is a mechanism to allow individuals to remain in society and do things, but separate themselves in a way that they are not actually transmitting disease to each other. Some of this has to do with limiting the size of the groups that they're getting together in. So for instance, if a festival was being planned and there were going to be 2,000 people, that festival would be canceled. We have social distancing and group gatherings of less than 10 allowed, and a minimum of 6 feet right now, because it's believed that in the current COVID crisis that will be enough in order to limit the amount of spread. So social distancing is a tool that's used to help mitigate spread, and things like isolation and quarantine are containment strategies. So these are tools that are being used in order to help contain and mitigate the spread of the disease.
The second part of my question had to do with what we owe to those who are more vulnerable than, say, we are. So if we're a young person interested in getting out and doing a little more socializing, and obviously able to spread the disease to 3 people, if that's what the common factor is, do we owe, and yet we're concerned about the socioeconomic harm that is also being caused to society, what do we owe those who are more vulnerable, where they do not necessarily have the same outcomes as, say, a younger person?
Yeah, I think this is the piece that really is a major focus of all of the conversations that are going on right now. It is very important that we understand that the public health initiatives are not geared toward an individual's ability to stay healthy, but the community and population's ability to stay healthy. We have an obligation to those people who are in the vulnerable, at-risk population. And to make a very long story short, although COVID-19, for young, healthy people that don't have any immune suppression, aren't on medications that are suppressing their immune system, they may just end up with a cold and a cough and some flu-like symptoms. They'll convalesce and do well with this. But each one of those people is going to potentially give it to other people, and eventually it'll make it to a vulnerable population. That vulnerable population is the population we're trying to prevent from having adverse outcomes. Right now, there are 65 million people over 65 years old in the United States. And I actually think that's a little bit of an underestimation now. We'll find out soon since the new census is going out. That's the vulnerable population. Age is an independent risk factor for a poor outcome with this disease. And then when we add on top of it, all of the people that are on either immune suppression or have autoimmune diseases, have had previous heart attacks and lung disease, all of these conditions put you at risk for an adverse outcome. I believe it is our obligation to pay attention to controlling the spread. It is an individual's obligation to the community to make sure the vulnerable population does not contract this disease. And until we have better medications, vaccines, and have enough herd immunity that lessens the impact on us, it's going to take us time and vigilance for us to do these things in order to protect the people around us.
All right, I've got a question from Sally here that says, so we currently have differences in mandates related to social distancing and allowing for groups to gather in our neighboring states. How do these different perspectives impact the good of our society?
I can start with that question. So one of my slides talked about the individual municipalities and states having statutes that drive and guide how the public health system is going to function. These do vary depending on the state you're in. And then it is the public health's, in the public health's purview to decide the distance and the community gathering size based on the individual disease and the transmission of that disease. In other words, it's based on risk. We actually have mandates now around us in the Missouri and Kansas region that are groups of no more than 10 and a minimum of 6 feet between each other. There is a request to have even less ability to roam around and put yourself at risk, because what we're finding now is that these strategies are not containing the growth as much as they could. Much of these tools have to be put in effect with a larger population or a larger portion of the population in order to be able to be effective. For instance, quarantine to truly be effective has to be applied to greater than 90% of the population when infections are out there. We can't just pick and choose the people that need it, but when everybody falls within that those quarantine criteria, they would be put in quarantine. So if we only do that for 50% of the people that need it, it's not going to work. But if we do it for 90% or more, it will. And so there is an obligation to figuring out these numbers. Those numbers do vary depending on where we're at. And even with this disease, as we started, we had groups of 200 or more were closed. Then we went to 100 or more were closed. Now we're at no group larger than 10. And we're even less in the states that have put mandatory social distancing in place.
Dr. D'Agostino, in Kansas especially, we've had some controversy just in the last few days around religious gatherings. For Christians, we're coming up to Easter weekend, which is a high holy day. And there are lots of faith communities that seem to be planning parking lot, drive-in sort of services this weekend. That worries me. Does it worry you?
I am worried. I am worried not so much about the drive-in ones where you can remain in your car with the people that you're living with. But what's more concerning to me are people that are going to be getting together because of the recent lifting of the restrictions of social distancing. I believe this is not in the best interest of public health, because the patterns of the infection rates are actually contributing to the decisions about why we are social distancing. And right now, by allowing gatherings, whether it's for religion or other, we do potentially put people at risk. Now, I believe everybody has the right and everybody has the desire to worship the way they want to. We're in the middle of Passover and Easter season, and so these are very, very high holy days that people want to respect their religions. And I believe that can happen in a socially responsible way at this point because we have vulnerable populations. I'm not as worried about the one you just talked about, driving into a parking lot and allowing those cars to remain closed off and only have the individuals that a person is living with in the car. I'm more concerned about people loosening or lessening the restrictions of the social distancing, which can only, it can happen and will happen when we're put in these environments. And so we already know that people have contracted COVID in religious gatherings. We've seen it, we see it across the United States. We also know that they've gotten it from being in groups at schools, and we know they've gotten it from playing sports next to people, and we know they've gotten it from playing in parks. So there's no exclusion. The virus is not discriminating about where it can infect somebody. So it is up to us to pay attention to these things.
All right, I've got another question from the audience. This one's from David. It says, should people be quarantined who have been tested positive and had been isolated for the recommended time?
So if a person has tested positive and they've been isolated because we know they have it, but we now need to observe them to make sure they're not getting better, and they have gone through the isolation period, right now, 14 days, they don't need to remain quarantined at that point. Now, I'll go one step further here because we're not yet doing this, but soon we're going to have a readily available antibody test that will allow us to identify people who have the immunity to the COVID infection. Once we know that immunity, that antibody response has occurred, we can take them out of isolation and allow them to re-engage in the community. Until we have that, though, we do need to go through the convalescent period, which is about 14 days.
All right, well, in the interest of time, we're gonna move on to our next speaker. Darrin, thank you very much for this presentation. You're welcome to stay on and continue contributing to discussion as we move on to our second presentation. Next up we have Erika Blacksher, who is the Associate Professor and Director of Undergraduate Studies in the Department of Bioethics and Humanities at the University of Washington. And as soon as we get these slides shared, we'll be able to turn the floor over to her. Oh, you're still on mute, Erika.
All right, am I off mute now?
You are now, yeah.
Excellent. Let me share my screen. And how's that? Can you hear me? Can you see my slides?
Yep, that's perfect.
Excellent, okay. I've had worse transitions. Hi, everyone. Thank you very much for inviting me to be a part of this collective learning experience. The CEO of the Center for Practical Bioethics a couple of weeks asked me if I could join this webinar as a panelist to talk about the ethical implications of this coronavirus crisis. Try saying that 3 times really fast. I've been working on it, I can't. But what are the ethical implications at the population level? How is it impacting our communities and our populations in the United States? I quickly agreed to do this. I've been swimming in COVID-19, metaphorically speaking, here in Seattle, which was the beachhead of the virus. But as I set about to prepare my presentation, I realized I had to sort of focus and be much more analytical about it. So what I'd like to do, if I may, is send my reflections around 3 questions that I've been asking myself since this COVID-19 crisis began to unfold here in Seattle, and of course, as we've seen, quickly spread around the country. Let me just apologize quickly for my voice. I hope you all can hear me. I do not have COVID-19 infection, but I do have something, some sort of terrible cold or something. So I'm hoping my voice holds up and that I do not have a coughing fit. So if I take a break to get a drink of tea, that is why. So here are the 3 questions I found myself asking, reflecting on the last weeks that we've been in this. Is the coronavirus pandemic an equalizer, as some have suggested? Who is being hit hardest and why? And could this crisis, this national crisis, this collective crisis, serve as a learning opportunity for all Americans? Could it help us see that our social safety net is threadbare, that our healthcare and public health systems are fragile, and that those hard realities affect each and every one of us? Could this be a transformative moment in our collective moral imagination to begin to understand that our fates are in fact intertwined? Early on in the outbreak, I heard this in several places in various sorts of media, the news media, on social media, that this coronavirus crisis was an equalizer, that it did not discriminate between rich and poor, that it did not discriminate between black and white. And that might be because some notable people became infected, and those infections found their way into the headlines, as is often the case. People like Tom Hanks, and for those of you who are Luther fans, Idris Elba, who's in the United Kingdom, Prince Charles, Prime Minister Boris Johnson, several of our US congressional representatives, all of whom are white men, which might suggest that, in fact, this is an equal opportunity killer. Still, I found it hard to believe, based on what I know about the production and the distribution of health and the production of illness and disease at the population level. Now, eventually, the headlines began to catch up with my early thinking because they began to reflect what we know to be the case about who gets hit hardest by both chronic diseases and, relevant to COVID-19, infectious diseases, minority and socioeconomically marginalized communities. So I began to see things in the press that I've shared with you here on this slide, these quotes. And just so you know, there is in my last slide, which I will not put up for viewing, but there is a resources or sources slide where these quotes came from. So I saw things like, this is a white collar quarantine. There is a pandemic caste system. Not everyone is equal in times of emergency. COVID-19 is going to devastate Black America. It always seems that the poorest people pay the highest price. Why is that? Now, some of these quotes speak to who's suffering from the economic effects of COVID-19. We've all seen those headlines. Some of these quotes speak to the health effects or the potential health effects of COVID-19. As we'll see, these types of impacts, however, are not unrelated. So to my second question, who is being hit hardest and why might it be? So I want to, there are very early data out coming from several states and cities, places like Michigan and Louisiana, cities like Chicago and Milwaukee, that suggest Black communities are experiencing extremely high rates of COVID-19 infections and deaths. And some of those rates are truly shocking. So I've put up here a slide from Johns Hopkins that indicates this. What this slide shows is that in many communities where Black people make up a relatively modest proportion of the population, a small percentage, they nonetheless comprise a disproportionate rate of deaths. Now, let me just underscore, people of all races, all ethnicities are dying of COVID-19. Now, it's also important to note that we know these data not because the CDC is reporting COVID-19 infections and deaths by race. The CDC does, in fact, collect these data by race and ethnicity, as well as by age and by gender. I've seen the form and the boxes are there for medical and public health professionals, officials to record. But to date, the CDC is not reporting COVID-19 infections and death rates by race. There is a movement afoot demanding that they do so, and it's vitally important information for public health and medical professionals and researchers to have. It is vitally important information for us as citizens in a democracy to have, because as Nancy Krieger has pointed out, if you don't ask, you don't know, and if you don't know, you can't act. And it's not just data about race and ethnicity that we need. We also need to gather and report data that connects COVID-19 infections and deaths to socioeconomic data. I've seen no similar call for for our professionals to collect COVID infection and death rates by measures of social class, such as education and income, but we need these data too, for if this illness is like most others, it will have a disproportionate impact on socioeconomically marginalized communities of all races and all ethnicities. White people, Black people, brown people who live in fragile circumstances are most likely to become infected and to die. This pattern in population health is well established. We can talk about it more in the question and answer time if you'd like, and it is likely to replicate itself on COVID-19 infections and deaths. Why might that be? Well, excuse me, just as a reminder, and we've all read the stories, anyone might get infected with coronavirus. I'm now speaking to probabilities and likely patterns. And there are three categories of people who are most at risk. So people, just to go back, so who's most likely to be infected? Who's most likely to be at risk of risk? Those are people least likely to be able to protect themselves from exposure, people with underlying health conditions, and combining those together, people who lack shelter, regular, steady place to be. So people least likely to protect themselves from exposure, less able to protect themselves from exposure are those whose work is either deemed essential for our collective survival, or they themselves need their work. It's essential for their personal survival. Now, while some of these essential workers, such as physicians, have ample or sufficient income and benefits that protect them, other workers are out there on the front lines working in very socially and economically fragile circumstances. So we've got grocery store clerks, we've got mail couriers, we've got truck drivers, postal workers, restaurant workers, nursing aides who care for elderly people that they are reluctant to no longer care for, and our emergency medical responders. These people typically work for low pay and few, if any, benefits such as healthcare and paid leave. I'm sure you all know that the United States is unique among advanced economies in not having guaranteeing paid sick leave. I was struck by the story, perhaps you all were too if you've seen it, or perhaps you've seen other similar stories, of an emergency responder. He was being interviewed on the PBS NewsHour, out there doing dangerous work and a lot of work, and he is working for very little pay, and he lacks health insurance despite his exposure. Now, the other people at grave risk are those who have underlying health conditions. So as Darrin has already spoken to, COVID-19 is particularly lethal for those with weakened immune systems, people suffering from diseases such as chronic lung disease, asthma, diabetes, heart disease, people who are smokers, people who are obese. And we also know, although I find that we often don't think about, people who lack homes are utterly incapable of protecting themselves from infection. They're living on the streets, or they're living in homeless encampments where there's no way to practice safe hygiene because there are no toilet facilities, and there's no way really to maintain physical distancing. My point here, just to be clear, just to underscore, is that less advantaged people are less able to avoid exposure and more likely to have underlying disease, both of which put them at a greater risk of COVID-19 infection. So who's most likely to die? So we've all read stories of, again, these strapping young men who get infected and go to sleep and don't wake up. I read a story just yesterday. So these are the early days, and there is plenty we don't know about the science of COVID-19. But as already noted, we've begun to see data reported by some states and some municipalities showing an outsized toll on communities of color. We also know, thanks to the Chinese Centers for Disease Control and Prevention, that when COVID-19 does take root in a person with chronic health conditions, it appears to be about 10 times as deadly. We don't have our own science yet. We aren't figuring that out yet, but we will. Because people in lower socioeconomic strata are more likely to have chronic health conditions and weakened immune systems, it stands to reason that COVID-19 will take a disproportionate toll on our most medically vulnerable, who, in our society, happen to also be those with the fewest economic resources, the fewest economic protections, and the fewest social protections. I would note that these same populations would be disfavored by widely accepted criteria, were they to be accepted and were we to need them, for allocating scarce resources such as ICU beds and ventilators. Those criteria, as I understand them, recommend prioritizing those with the best chance of survival, those with the best odds, should receive hospital beds and ventilators. That allocation likely hews to many of our moral intuitions. But notice, those with the best chance of survival are most likely to be those in good health, who, as I've already noted, come from the ranks of the better off. Those with the worst survival odds are likely those who have weakened immune systems or underlying serious health conditions, who are most likely to come from the ranks of the worst off. Our poor, our near poor, or people of color. To be clear, these criteria are ethically justifiable on utilitarian grounds and arguably by the lights of other schools of moral thought. I've been reading about this. There are deontological approaches, justice approaches, contractarian approaches that might justify giving these scarce resources to those with the best survival odds. In a perfectly just world, I'd have no beef with them. But I think they should trouble us all when they're deployed against a background of entrenched social and racial inequities. When that is, they're used in the context of serious injustice. Now, I've not even talked about, and I won't talk for long because I want to leave plenty of time for discussion, the economic toll. Here I've just been focused on the health toll that we think it's taking, that we see it taking, and that it might take. But I'm sure we've all been immersed in scary headlines and scary stories about what's happening to our economy. I learned from Darrin yesterday that we are no longer the number one in the global economy. We are number two, second to China. These numbers are outdated, but the latest Labor Department records show that we've lost over 700,000 jobs. I've found research suggesting that Latinos are particularly hard hit and that women are particularly hard hit. Economists are predicting something like the Great Recession, if not worse, some 20 million job losses and an unemployment rate of 15%. So look, the economic wreckage of the coronavirus could sweep us all up. Maybe it's coming for us all, but it will take an especially big toll on those with the least. And just a little factoid I came across that I was unaware of and I found striking, and I want to share it with you all. Some 86% of US workers are employed in the service industry. The service industry has been devastated. Now, these people typically have low pay, few benefits, and uncertain hours. They're sometimes called the economic precariat. That's a smash-up, a mash-up, if you will, of the precarious proletariat. These are people without security or predictability in hours, pay, and benefits. We've seen many of their gig economy jobs go by the wayside. And so all of this has sort of left me reeling and left me wondering, could this crisis be a collective learning opportunity that catalyzes transformative change in our country? Now, as many have noted, the coronavirus has laid bare our threadbare social fabric, its fragile public health infrastructure, our very thin social safety network. And one prominent example of our vulnerability, which I think came to a shock to many, myself included, is having a test for coronavirus. People were and remain shocked by America's failure to have a reliable test and to have a test in ample supply. After all, we've got the CDC, we've got the Gates Foundation, we've got the Johns Hopkins Institute, we've got the National Institutes of Health. I could go on. We're a biomedical powerhouse, but many weeks into this crisis, where are the tests? They're coming. I've been tested, but that's only because I work at the School of Medicine at the University of Washington. We know that they're coming online, but they're not readily available. And notice, even when we have a test, not everyone will have access to it. Why? Because not everyone has access to healthcare. And even those who do have access to healthcare will not know whether they can afford to get tested or afford the care that they might need if they test positive. I, like many of you, have read stories of people receiving 4- and 5-digit medical bills for their coronavirus-related care. So America stands alone among advanced economies in not having an approach to healthcare that covers all of its people. And it doesn't have to be that way. We could change this if we had the will to do it. But it would require that we get a grip on how our fates are intertwined. I've become convinced of that. And that we make a commitment to mutual assistance on matters that matter most. So I want to leave you all with an observation and a question. And excuse me for just a minute. Let me help my throat. The first observation, the observation relates to the state in which my husband and I live and work, which is Washington State. And as you all likely know, Washington State was the first hotspot for the coronavirus crisis. The first confirmed US COVID-19 case on January 21st was in Washington State. The first COVID-19 related death in the US was also in Washington State. That death turned out eventually to be one of 35 COVID-19 related deaths to occur in residents living in a Seattle nursing home called Life Care Center of Kirkland. Now, Washington State now has about 8,600 positive cases, and our death toll just yesterday or the day before reached 400. The good news is that Washington State's caseloads are leveling off, and the death rate is slowing. Our governor, Jay Inslee, has sent extra ventilators to New York and other states that are now in the eye of the storm. So why has COVID-19 stemmed in Washington State? Well, the full story is for someone else to tell and for another day. But let me suggest a few likely contributors, what we experienced here in the state of Washington. Governor Inslee was early to implement a mix of both mandatory and voluntary initiatives to keep people from physically interacting. Mandatory closures of bars, restaurants, retail centers, recreational facilities, followed by a voluntary stay-at-home, stay-healthy initiative for all Washington residents. We saw major employers who employ tens of thousands of people like Microsoft and Amazon very early on kept their workers at home. Now let me say kept their office workers at home, right? Not the people doing the delivering, not the people doing the boxing up, not the people stocking Amazon shelves, but their office workers, like my work, like my husband's work, seamlessly transitioned into our home, where we both have offices. So Governor Inslee justified these various proclamations and initiatives on grounds that they would keep all of us protected, but especially on grounds that the most vulnerable of us would be protected by these measures, the elderly and those with compromised immune systems. He was asking people to give up something vital, something important, a prized right, really, which is their freedom of movement, and in many cases, their jobs, to keep others and all of us safe from coronavirus. And that has led me to thinking a lot about solidarity. What is it? Why don't we seem to have much of it in America, if any? And so what I want to do just to get us thinking is share with you a proposed working definition of solidarity. This comes from a 2012 publication. You have the site at the bottom of the slide. A couple of researchers trying to understand where solidarity shows up in the bioethics literature. Turns out, doesn't show up very often. And there's no sort of convergence on a singular or consensus definition of it. They proposed this definition, and I'd like us to think about it as a working definition. Shared practices reflect, so what is solidarity? They suggest shared practices reflecting a collective commitment to carry costs. What kinds of costs? Financial, social, emotional, or otherwise, to assist others. I've been asking myself during all this, do I see acts of solidarity amidst this crisis? I do, by the way, is my answer. I'm curious to know what you have seen. And what might an America informed by an idea of solidarity look like? So on that note, I see that it's 10 till, and I'd like to open it up for questions.
All right, thank you again. Or once again, the Q&A function and chat function are open. So if you have any questions or would like to contribute to the discussion, you can do so there. So be paying attention to it.
So I have a question, Dr. Blacksher. So in a time of pandemic crisis like we're in now, is awareness of ethnically and socioeconomic disparate death rates, for example, is this merely a learning opportunity? Or maybe I should put the emphasis on merely a learning opportunity, something that we should remember maybe after the crisis with correctives that would follow? Or is there something, or are there some things that should be done differently now? Say, for example, in our drafting or in our mitigation, our quarantine practices, to get back to the first talk, or in our drafting of triage protocols, or in regard to pandemic crisis standards of care. Is this mostly learning opportunity for the future, or do you see that there should be things that ought to be altered now to address disparities?
Sure, thank you for the question. And I'm trying to, Terry, please call me Erika, and to everyone. I'm hoping that by eliminating my screen, I'm told this is better for this conversational part of the seminar. I thank you for the question, Terry. And I would say both and. I do think there are things we are obligated to do now to protect our most vulnerable, our socially vulnerable, our economically vulnerable. And that would be in the way of, and I think some of, that Darrin, you did not speak to this. I saw this in one of your slides, that we should ensure that there are protections for people who are being isolated, who have lost their job, to ensure that they are protected either through unemployment insurance or, and there are various ways of doing this, ensuring that people have, that they can get tested, that tested will be paid for, that any care related to the test, if it's positive, will be covered. So I do think there are things we can do right now, both in terms of kind of direct COVID-19 hits in terms of paying for tests and paying for COVID-19 care, and in terms of protecting people with financial resources, whether that be through unemployment insurance or some other mechanisms, who have lost their jobs due to the devastating toll this has taken on our economy. And what I started to say was, it is really quite interesting, because as I understand it, some economies, some countries have taken very different approaches. Some countries have, instead of giving people unemployment insurance, in other words, instead of allowing them to become unemployed, what they've done is they've fed money through small businesses and businesses to keep their people employed and on the payroll. I think that some of that is happening here, and it's a very interesting question to mull about the psychological effect of not losing your job and receiving unemployment insurance, but rather staying employed, maybe even at a reduced salary, but being able to keep your job, stay employed during this crisis. So I do think there are things we can do now, and I absolutely think that there are things we must do after. And my fragile hope is that this crisis is a teaching moment, as we say, in those of us who are teachers for a living in some form, whether we're teachers in our public schools or teachers in institutions of higher education. I hope I've answered your question, Terry.
You have, thank you.
All right, we've got a couple of questions coming in from audience members. The first comes from David. It says, 2 areas, economy and health. What's the best way to merge the outcome? I suppose here we mean the make sure that both of them see positive outcomes.
Right. So, right. Notice how I noted at the beginning, I flagged at the beginning of my remarks that our economics are intertwined with our health. Our wealth and health are travel together. How do we make sure we get a good outcome on both of those indicators? I don't know how to say much more than what I've said in response to Terry's question. I mean, I think we need to have very aggressive types of stimulus packages, things you are seeing in Congress. One note I would make about that, it is vital that we protect not only the banks and Wall Street and big businesses, the airline industry, for example. And I'm not suggesting we don't do those things, but this cannot be like the Great Recession where we save Wall Street, but we don't save beleaguered individuals. We need to, this cannot be, once again, kind of a winner-take-all situation where we, if you will, make public the losses, but we privatize the gains. We just can't continue to have an economy that works that way. There are, as I'm sure many of you know, many, many, many books being written for the last decade about the crippling effects of an economy that is this unequal, that has such unequal impacts on its people.
Got another one from Chris that says, tough question on my mind. Many triage mechanisms, for example, for ventilators, use criteria like presence of pre-existing conditions that will likely bias against persons already suffering disproportionately from structural inequalities. Can you speak about alternative mechanisms such as lottery or random selection?
Yeah, well, thank you for making that point. I mean, that was exactly my point, which is sure doesn't seem fair against in a very unjust world. So what about the lottery? I've actually wondered about the lottery when I'm walking my dog. Should we have a lottery system? Should it come to that? And I was reminded of an article that was discussing how we might, somebody behind a Rawlsian veil of ignorance might think about what a just distribution of scarce resources, and let's say that they're ventilators and ICU beds in this case, what might a just distribution look like? And in this particular article, this person was arguing that that person, not knowing anything about themselves personally, what their social position is, what their race or ethnicity is, whether they're male or female, whether there's some other sexual orientation, whether they're highly educated or not, what their income level is, and the case that this person was making is that behind a veil of Rawlsian ignorance, we would, in fact, endorse distribution criteria of the sort that you just noted, which is, that those with the best chances of survival should get the scarce resources. But I wondered if I were behind that veil of ignorance, I might just as likely want a lottery system, right? If I don't know anything about who I am, any of my personal characteristics or attributes, I might very well think that a lottery is fair. So a lottery is an interesting idea. I can't really speak to, I think others are probably better equipped to speak to some other sorts of approaches to resource allocation inside the clinic, but I think your notion of a lottery is an interesting one.
Darrin, did you want to jump in here?
Yeah, there's, I think we have an opportunity here to also open the door for maybe a future webinar. This is one of the biggest challenges with public health. Public health is a mechanism to allow resource distribution in a place where resources are limited. We're also touching on the concept of fairness versus equality, and everybody having the same versus those who have need get. This is a question that comes up all the time in the distribution of healthcare in all settings, because again, this is a limited resource that we have to make sure is appropriately applied. These decision criteria are based on science. They're not based on, and having been in the situations where I've had to make these calls in an ICU, they are based on the science and what we know about the particular diseases that we're treating. They are not guesses, but they are estimates based on mathematical models and working with the tools that we have. The other challenge here, which I also believe is a good place for us to have a conversation, is why don't we have enough ventilators? Why don't we have enough dialysis units? Because these are the tools that people are going to need. And we can get into a much more deeper conversation related to the production and scaling up of these things. But what is it about having these tools in reserve that allows us to make these decisions a bit easier and not have to ration? Remember, in the United States, rationing is a four-letter word. It's something we don't like because it means some people don't get and some people do. What are those elements that allow this to be as fair as possible? And I think Erika did a great job answering that. And I think these are questions that we probably ought to do a deeper dive in the future.
Darrin and Erika, thank you very much. This has been really enlightening and kind of sobering, I guess, too. One of my closing comments I would just like to do is, in addition to expressing my gratitude, is thank you for posing these questions in an educational format. Terry and I have been talking just lately about how often this conversation around this whole illness is all about the war metaphor. And we really can do much more, I think, in terms of asking ourselves, how is this crisis educating us in terms of what we must do now and what we must do in the future? And I think this has been a tremendous contribution to that discussion. So I thank you both, and I'm going to probably take you up on your request to explore another webinar. So with that, I'm going to turn it back over to Matthew. Matthew, thank you so much for hosting us today, and let you have the closing remarks here.
All right. Well, for everyone who submitted questions that I wasn't able to get to, I apologize, but we've come up against our time here, and I just want to be respectful of everyone. So I appreciate Darrin and Erika taking time to join us today, and just remember that these webinars can be found on our YouTube channel, so you can find them by searching Practical Bioethics on YouTube. And we will continue to sort of add additional content to this series. So thanks again for signing on today, and thanks Darrin and Erika and my colleagues for contributing to the discussion, and we'll catch you next time.
Thanks, everyone.